Health policy can be defined as the decisions, plans, and actions that are undertaken to achieve specific healthcare goals within a society. Those goals may cover topics of financing, the delivery of healthcare, the access to care, the quality of that care. Health equity will cover health disparity as well as healthcare disparities. Those are certainly very different things. When we speak of health equity, what that really means is that everyone has a fair and just opportunity to be healthy. To get there, we have to remove the obstacles to health, such as poverty, discrimination, poor education, lack of housing, lack of just the very access to cutting-edge technology to use in healthcare systems. Health disparity, on the other hand, is really a difference in health status that is closely linked with social, economic, and environmental disadvantage. Healthcare disparity really refers to the differences in the quality of healthcare provided that are not due to access-related factors or clinical needs, preferences, and the appropriateness of the intervention. When I think of healthcare disparity and innovation, what comes to mind immediately is opioid use disorder. According to the DSM-5, opioid use disorder is defined as a problematic pattern of opioid use leading to clinically significant impairment or distress. In the United States today, we have in excess of 2 million people who are diagnosed with an opioid use disorder, and that number continues to climb in the light of COVID. In Washington, D.C., where I am located and I conduct my research, we've had 1,325 total deaths due to opioids between January 2016 and September 2020. Those were the latest figures from the coroner's office. But of more concern is the trend that we have seen in light of COVID. That number has gone up significantly. Year to date, we have 317 opioid deaths. The cases of opioid deaths now involve more than ever some fentanyl analog. It increased from 62% in 2016 to 94% year to date in 2020. 84% of all the deaths, however, due to opioid use were among Blacks, with a consistent trend across the years in Washington, D.C. That's concerning to me because the deaths are going up, but the population of people of color continues to go down based on other social things that are happening. Deaths due to opioids were the most prevalent in the age group 50 to 59. 35% of those individuals who died were within that age group. And that's also very concerning because individuals are in the prime of their lives. But what is even most concerning to me as a researcher, as an educator, as an administrator, is that the lion's share of the prevalence of those deaths really occurred in 3 wards, wards 5, 7, and 8. 91% of all the deaths, 91% involve some illicit fentanyl analog. Now, what happens when a patient is undertreated or not treated when they have an opioid use disorder? They experience withdrawal. Those symptoms go up significantly. Criminal activity and incarceration can indeed go up as well. The risk of exposure to HIV and hepatitis C, 2 very expensive diseases to treat, goes up significantly. And of course, as I mentioned prior, the risk of death goes up astronomically. As productive members of society, productivity goes down. The overall health and well-being of our citizens goes south. And that's a challenge. That's something that we do have to address. Now, treating OUD requires a biopsychosocial approach. and this is considered the gold standard. And in that approach, it includes what we call medication-assisted treatment. And one of the drugs, I would think the most prevalent, the most successful one to date, is buprenorphine. The challenge with using buprenorphine is that some patients don't respond to the FDA-approved dosing and may require higher doses. That warrants a question. That warrants an innovation question in particular. How do we address this as scientists? How do we address it as healthcare providers? How do we innovate to eliminate the disparities and save lives? Well, I say we do this through pharmacogenomics. What is pharmacogenomics? Pharmacogenomics studies how inherited genetic variation, also known as polymorphisms, impact drug response, and is a combination of pharmacology and genomics. When information gleaned from pharmacogenomic research is translated from the bench to the bedside, we refer to this as clinical pharmacogenomics. You receive one allele from your mother and one allele from your father, and the combination of the alleles makes up your genotype. Each of the alleles is associated with a particular level of functionality, and the physical presentation of your genotype is what we call the phenotype. The phenotypic presentation is of importance as we innovate in healthcare, as we innovate with pharmacogenomics. Some patients present as poor metabolizers, meaning they will not metabolize certain drugs based on particular genes very rapidly. So the drug may accumulate. Some present as intermediate metabolizers. Some present as normal or extensive metabolizers. And then we have those who present as ultra-rapid metabolizers, meaning their genetic pattern allows them to really metabolize the drugs much faster, and it clears their system without really getting to the necessary therapeutic concentration. My team and I conducted a study looking at 113 patients in Northeast Washington, D.C., who are undergoing buprenorphine-based OUD management to determine if their clinical pharmacogenomic testing for the CYP3A4 and CYP3A5 gene would impact their treatment outcomes. Just for clarification purposes, the CYP3A4 gene is where buprenorphine is metabolized, and for information purposes, a large number of pharmaceuticals on the market today is metabolized by the 3A4 gene. Our research suggests that patients with at least one copy of the 3A4 star 1B allele exhibit an accelerated rate of metabolism compared to what we call the wild type or normal, which is CYP3A4 star 1. When those patients were dosed according to pharmacogenomic guidelines, these patients do much better. They exhibit less withdrawal. Thus, they don't supplement with illicit substances to dull the effects of withdrawal. Our findings are clear that innovation surrounding pharmacogenomics should be the standard of care, and it needs to be a formidable piece in the arsenal as we guide health policy. I'm of the opinion, and I'm collecting additional real-world data to show that using pharmacogenomics as a standard of care is the way to go.